keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
I am Jagat Narula, Editor-in-Chief of JACC Cardiovascular Imaging. In the May issue of the journal, we are going to be publishing a very interesting report from Dr. Ueda's group from Osaka, Japan, which has an accompanying editorial from Dr. Renu Vermani and her colleagues. First, I will ask Dr. Ueda. Dr. Ueda, can you please explain your study in 2 sentences for us?
Okay. We observed coronary artery by angioscopy at baseline and at 10 months follow-up after Cypher drug-eluting stent implantation, and found that the vessel wall becomes yellow where there is no yellow plaque at baseline, and also the yellow plaque becomes more intensely yellow.
So at 10 months after the drug-eluting stent implantation, the yellow plaque becomes more intense yellow and the white intima becomes yellow, suggesting thereby that in stent there is atherosclerosis. Does that really mean that the vulnerable plaques are developing inside the stent? Is that true, Dr. Vermani?
It certainly could be true, because we've observed it in saphenous vein grafts, which are very incompetent endothelium. When you put a bare metal stent, within a year, you can see these changes of atherosclerosis, but not in native arteries. If you put in bare metal stents, you do not see this atherosclerotic change at 1 year out. Now, we have observed the same thing Dr. Ueda has observed, that when we look at our drug-eluting stents at 15 months, 30 to 40% will have atherosclerotic change. When we match those with our bare metal stents, in fact, it took them 4 years to get the same kind of change.
So was there any difference in the patients who had their coronary interventions for acute coronary syndromes or who had it for stable angina?
Yes, almost all of the carpal lesions of ACS have yellow lesion, but about 6% of the stable angina patient have yellow lesion.
Dr. Vermani, is this vulnerable plaque that is developing, does it really have a potential to rupture and result in late stent thrombosis?
It certainly could. From our work, we've also observed in those with restenosis, they seem to have, not every restenotic lesion after drug-eluting stent, they seem to get atherosclerotic change, which we call from observing foam cell formation as well as necrosis of those foamy macrophages undergoing apoptosis, and free cholesterol or fibrin deposition. We've observed all these changes, but we've not seen a true plaque rupture in a drug-eluting stent. Mind you, these stents have not been in place for too long, and the number of cases that we have beyond the 1 year period and 2 year period are not that many. So it's a matter of time, I believe we will see these changes of plaque rupture within the stent.
So does that really mean that it is not only the endothelial healing problem, it is something more than that?
Well, I think, as you know, atherosclerosis occurs from changes in the endothelium itself, that there is a defective endothelium. I think the endothelium that develops in drug-eluting stents is also defective. Not only is it not fully covered, the stent struts, but also the ones that are covered is incompetent. And therefore, I believe this allows lipid to diffuse into the arterial wall and lead to these changes of foam cell formation.
Suggesting thereby that you will have more thrombogenicity as well as the development of the vulnerable plaques.
That's what I believe, since our incidence is fairly high at 15 months, which to me is sort of frightening, that perhaps this is going to be a phenomenon that we should be careful for. As you know, in drug-eluting stents, we are showing 0.6% increase in stent thrombosis per year. Up to 5 years, they've observed this.
So then what is the take-home message? Should we be developing different stents, or should we be selecting patients differently for using the bare metal stents versus the drug-eluting stents?
I think we should be judicious in our use of drug-eluting stents. I think large vessels, as has been shown by the German group, Castardi's group, that really they don't show a benefit. If you compare drug-eluting stent with the best bare metal stent on the market, you really don't see a benefit of drug-eluting stent because they heal well, the bare metal stents, and it doesn't lead to restenosis. The rates are very similar. Whereas in small vessel, absolutely it makes a difference. We should use them more in patients who have diffuse disease, in patients who have distal disease. Those are the ones who need drug-eluting stents.
We are indeed excited about this particular report. I think it is going to create some stir in the scientific community, whether it was only the non-healing of the endothelium or is it the development of the vulnerable plaques in stent. Thank you very much.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.